this area. I'm not a paramedic. We do have paramedics that do this course as well. This is the shortened course. Sounds like a lot of you are familiar with this, but don't hesitate to stop me if you have any questions. So, there we go. So, in terms of you've all seen the EZAO Generation 3 device. So this is the new one. It comes with a sealed lithium-ion battery in it. Shelf life of 10 years, about 500 uses out of it. The most important thing to know is that when checking the battery life, you should see a green light here. If for any reason you pull it halfway down or you start to pull the trigger and it flashes red, that means you've got about 10% battery life left. In terms of cleaning, you want to just wipe this with a damp cloth. But definitely don't autoclave or submerge it in water. Okay, so indications. In terms of indications for EZIO, in adults, you've got six sites. So you've got the proximal humerus, the proximal tibia, and the distal tibia. With pediatrics, you've got the distal femur now, which is a new indication, proximal humerus, proximal tibia, and distal tibia. I don't believe the distal femur is on your protocols, so just a disclaimer here. Anything I see in here is, is not to supersede your protocols here. But so contraindications for using an IO. So one would be a fracture of the target bone, and that would mean if it was the tibia, you'd have both sites that were compromised and you want to move to the other site. Infection or suspected infection at the site of insertion. The inability to identify the landmarks. Pediatrics, sometimes it's tough to find the proximal tibia, so you may want to move on to another site if you can't find those landmarks for sure. Current IO or attempted IO within the last 48 hours. And then lastly, prosthesis or an orthopedic procedure near the insertion site. So if a patient has a scar up here and you suspect that they may have been through a surgical procedure. Hi, did you have a question?
Well, if you're finished what you're saying, I have a question about
Yeah.
that. Well, like for a knee replacement, are you going to be able to use your proximal tibia?
So in that situation, you should be able to go down to the distal tibia, right? So it's the fracture of the bone that you would want to move to another bone altogether.
I'm talking about the prosthesis. Prosthesis. You've had a knee replacement.
That's when you go to the humerus, I think.
Just stay away from any knee zippers.
So you've got a knee replacement, so your proximal tibia is 3 centimeters down, 2 centimeters medial to the tibial tuberosity. I'm not sure that would be an affected area on that.
Just the word near, how near?
It'd be on the site itself. So let me. What I'll do is I'll take that question down and I can get some more information, direct information on that. I'll send it to Shawn. So. But no, good question. So, IO has been around for years. Initially back in the 20s during World War II, and then it's kind of resurfaced again. But it's a great area for IV access when you can't gain IV access through the air. Typically done at the distal and proximal ends of a long bone. You've got cortex in here that's typically 3 millimeters or less thick, so it's easier to get through than it might be somewhere else on the bone. And once you go through the cortex, you've got a highly vascular area that acts as a great way for IV access. This area in here is yellow with red bone marrow. The most important thing is, in order to gain access, is you need that fast flush. 5 to 10 milliliters of saline for adults and 2 to 5 milliliters of saline for pediatrics. So once you displace that, you can get flow in there. And then that's something you also want to check as you're bringing the patient in, is to make sure you've still got patency at that area. So essentially, the bone acts as a highly vascular, non-collapsible vein. Okay, so for whatever reason, the video on this isn't working, but it was a real-time study done with one of our doctors with fluoroscopy. And when using the proximal humerus site, it shows, in contrast media, it shows the dye reaching the right atrium of the heart in less than 3 seconds. So proximal humerus versus the tibial sites, there's a difference in 2 things. One is the time to the heart, and the other is the amount of infusion you can do. So with the proximal humerus site, you've got up to 5 liters per hour of fluid under pressure. Another study was done and found that in terms of peak serum time of epinephrine, the proximal humerus site was also, the time was equatable for that in a central line. So if you've got a patient that may need a central line, this is more in the hospital, but the proximal humerus site may be a better choice for them rather than having to go through the procedure of putting a central line in. Okay, so proximal humerus site identification. A lot of people get concerned about that. I found the video. I'm gonna show the video here. It's actually a larger site and a bigger target than the tibia. So I'm going to try to pull up a video here.
You want some help?
Yeah, that would be great.
Yeah.
Okay, now you can, there we go.
I'll be demonstrating the proper insertion of an intraosseous needle in the proximal humerus. Proximal humerus has many benefits, one of which is it's a large target. And just to appreciate how anterior to the midline of the proximal humerus lies, one can take the palm of your hand and actually palpate the anterior portion of the proximal humerus with the palm of your hand. The patient's hand should be placed over the abdomen in order to help internally rotate the humerus, to keep the intertubercular groove, which is where the biceps tendon is, medially out of the field. The site of insertion is the greater tubercle, which is on the anterolateral aspect of the upper arm. In order to find the proper landmarks, I'm going to go over some techniques that you can use in order to feel a proper bone anatomy. The first thing that should be done, with the patient's hand over the abdomen, and the elbow tucked in, the arm deducted against the body, one should place the ulnar aspect of the left hand, in this case, in the axilla to help define the anterior border and keep myself out of the medial aspect of the arm, which is where the brachial plexus resides. The other hand should be placed in a perpendicular fashion in the midline of the upper arm, and where my thumbs will come together will define a line over which I should be palpating to feel for the surgical net. The proper target is about 1 or 2 centimeters or 1 finger breadth above the surgical net. So I'm using my hands in order to define where along the upper arm I should palpate. And palpating up and down, I will feel for the surgical net. It will feel like a golf ball on a tee. Where the golf ball meets the tee, that's the surgical neck. The proper placement is approximately 1 or 2 centimeters or approximately 1 finger breadth above that. So I've determined my landmarks. I'm eyeballing where I believe I'm going to be putting the needle. And I want to make sure I'm putting the needle at approximately 45-degree angle, and I'm flush and perpendicular with the plane of the skin at that insertion point.
All right, so comes the fun part. I need a volunteer.
Here, right here.
No. Look at Fitzgerald stepping up.
Do you guys want to take a minute to try to find it on your neighbors?
We don't like touching each other.
Okay.
Liar.
I hear you. But just some quick things. So what happens when you put the hand across the abdomen is you take the one thing that you can hit in there that would be damaging, which is the biceps tendon, and you move it all the way over here out of your view. Now, obviously, you folks have patients that are in supine position, probably more often than not, right? So, in a supine position, what you're going to do is you're going to take the thumb and you're going to move it inward like this, and that's going to bring the biceps tendon all the way over here and get it out of the line of sight. And then lastly, and I don't know if you said it on this, but it's very important that you secure the arm with a limb holder, restraint, something like that. Because once that IO is in there, especially in a moving ambulance, if that arm goes up above about a 60-degree angle, that IO has a good chance to pop down. And then typically we recommend for the proximal humerus site, the 45-millimeter yellow needle. Okay, so tibial site identification, I'll bet you folks are all pretty good about this, but basically in an adult, you're going to extend the leg, and you're looking for that tibial tuberosity. Once you find that, it's basically 2 centimeters medial. If you ever can't remember which way to go, just remember big toe IO. Does that make sense? It's early, I know. So if for any reason you can't find the tibial tuberosity, it's typically 2 to 3 centimeters distal from the patella, and then 1 to 2 centimeters medial. And what you're looking for is the most flat aspect of that bone there. Pediatrics or infants, that tibial tuberosity typically hasn't grown in. You may not be able to feel that. So that's where you're looking to do basically 1 centimeter down from the patella and 1 centimeter medial. And you're feeling for a flat area there. So this is the distal femur for pediatrics. I'm going to jump over this since it's not part of your protocols. If you do get to a point where you're doing this, the most important thing is in this situation, you want to secure the leg of the pediatric patient as well. Okay, so here are our needles. Can anyone tell me what that is? Okay, so a lot of people used to call it the pediatric needle. A couple of changes have come about in the last couple of years. There's no separate indication for pediatrics or adults anymore. This is indicated for 3 to 39 kilograms. This has changed. This is now just simply indicated for 3 kilograms and above. Where the 45-millimeter needle is indicated for 40 kilograms and above and recommended for the humerus, as well as for situations where you may have a lot of adipose tissue and need a longer needle. You see the black lines there? It's super important that when you're checking that needle that you see the black lines. This last one here near the hub is at a 5-millimeter mark. if when you're checking, when you choose your site and you're going to put that in till it meets the bone first, the most important thing is to make sure you see a black line. If you don't, then you know to either move to another site or move to a longer needle. Okay, and kind of went over this again. Before you pick the needle, you're going to pick the site and you're going to estimate the tissue depth. You're going to do this by palpating, and you know, it's something I think as you use it, some of the experienced users can tell this really relatively quickly. And then once you're going to basically, the driver is magnetic, and once you kind of pop the needle on there, you're going to go into your site, and you just want to once you hit bone, you want to make sure that you see one of those 5 millimeter marks. And again, 90-degree angle to the tibial insertion sites and 45-degree angle to the proximal humerus site. Okay, so this is an egg video, which I'm going to spare you folks. But the purpose of the video is to really, situations that can arise is, especially using the tibia, is when you're driving or drilling it in, sometimes it can lock up. And the reason why that happens is you may be out of battery too, so definitely check the red light, but you may be bearing down on too much. So the way these needles were designed and the way this is designed is for tactile feedback. So once you get past that cortex, you're going to be able to feel the lack of resistance and know that you're in. In a pediatric patient, it's recommended that once you feel the lack of resistance, you stop. There is a reaction for some is once you feel the pop or the lack of resistance in a pediatric patient to pull back on the driver. So that's why I brought some eggs over there if any of you want to practice, and just real light pressure and then feeling that lack of resistance when you go in, and then learning how to stop without pulling back. And again, just other items. The Easy Connect, we recommend that you prime that first, either with lidocaine if you have a conscious patient, or saline, so that you have a syringe ready. This is a stabilizer, very useful in a situation where you've got a proximal humerus insertion. It basically goes over it, and the stabilizer has about that much depth, so if you're not in towards the bone all the way or in towards the skin, you've got a way you can snap on and keep that in place. Just kind of extra protection for the patient. Okay, again, use minimum pressure. When you pull, basically you use 2 hands, you pull this out first, and then you're going to hold the bottom part and then twist clockwise to remove the stylet. And then you're going to flush and then immobilize with if you are using the stabilizer. One important aspect is when you're taking the needle cap off, let me go grab a needle here. So kind of going back a little bit, the needle cap here, a lot of people sometimes, especially in a quick situation, will want to turn that. So if they're not looking, they'll turn that and the whole thing will come off and they'll drive this into a patient. I've seen this a dozen times. So it's important when you're taking the needle cap off that you put this on the driver and then you pull that straight out. Okay, so flesh and medications. Again, flesh super important. Infants, children, 2 to 5 milliliters of saline. Flesh for adults, 5 to 10 milliliters. That's something that can be repeated, as you're checking for patency of the line later on. And this, of course, would do for a patient that is not cannot feel pain, an unconscious patient. So, in a situation where you have a conscious patient, going into the bone with the driver is usually rated on a scale of 1 to 10 at a 2. However, the flesh is a 10 plus. It's off the charts. And I know I've talked to a lot of people that get scared because patients just go into this extreme pain once they're, even if you're using lidocaine. So what we recommend, and again, not to supersede any protocols that you have, is we recommend for adults 40 milligram initial dose of lidocaine. For infants, it would be a half milligram for each kilogram of their body weight. So initial dose is actually going to be pushed over 120 seconds. That's a lot of time. It's a lot of time to sit there and push 2 milliliters of liquid. So patience is a virtue in this situation because you can bring that pain scale down to about a 2 or a 3 with the patient. It's all about just letting it dwell in there. And then after you've spent 2 full minutes pushing it, you're going to spend another 60 seconds letting it dwell. Then you're going to do your rapid flush, and then after that, you're going to follow that with 1/2 of the initial dose. So in this case, it would be 1 milliliter for an adult of lidocaine, epinephrine, and preservative-free for 60 seconds. And again, if you've got a long drive time to the trauma unit, you can manage that throughout the process. Okay, just in the needle packet, you've got your needle, you've got your Easy Connect where you're going to prime, never to be used in the sternum. And then you've got this wristband. Do you all use the wristband in here? It's a little pink wristband. Shawn's holding it up there. Yeah, it's real important. Once you get that in there, you've got ability to write the patients. The most important thing is really the time and date the item goes, the IO goes in, because you've got how many hours before it needs to come out? 24 hours, yes. So that way, you're not getting calls from the hospital asking what time that IO went in there. They've got it on the wrist already. You want to be checking for infiltration, extravasation, repeating the flush if necessary, and then checking for the pain scale and actually dosing additional lidocaine if you need to. Removal, if you ever need to do it, is you're going to have how often do you have to remove one of these? Ever? Okay, so if something happens and you need to do it, you're going to take that same syringe that you were dosing with, you're going to screw it onto the hub, you're going to bring pressure up, clockwise, pull straight out. But you use the syringe as kind of a torque wrench to get it out. One great thing about us is over to the right there, there's an app you can download. It gives you a lot of good information, videos. You search EasyIO on the App Store, Apple, or the other one, Samsung. That number there is on the wristband. It's on this as well, but any type of clinical questions that may come up, that's staffed 24 hours, 7 days a week with nurse practitioners, paramedics, and RNs. Ton of education resources. That's that site that we played that video from has all sorts of videos in terms of cadaver videos and questions. And then we've got a whole clinical team, and we put together things like cadaver labs and more intense trainings and that type of thing. So that's all I have in terms of this. Thank you for your time. And then right behind you, if you want to take a few minutes, you've got some hands-on, you can practice with eggs. And then I've got some humeral bones there, both pediatric and adult as well. And then lastly, any questions for me? Sure, thank you.
Thank you.
Thanks.
So we're